Good afternoon, ladies and gentlemen. It's my honor. I'm Khalid Abdelkarim, Professor of Clinical Oncology, Ain Shams University. It's my honor and great privilege to welcome you to this special symposium sponsored by our dear friends at Amgen. And it's my great honor to introduce one of the legends of hemato-oncology in Egypt and Africa and Middle East, Professor Dr. Mirvat Matar. And I hope we are all going to get a great benefit and enjoy her presentation about the management of relapsed refractory multiple myeloma. This comes in a very good time for us, as I'm part of the hemato-oncology and CNS oncology at Ain Shams University. So welcome, Dr. Mirvat, to the 7th Ain Shams University International Clinical Oncology Conference. Please, the mic is yours. Thank you.
Next time, maybe we can meet in person, inshallah. Next slide, please. So how to attack the myeloma cell? You can attack the myeloma cell in different ways. One of them is, the most famous, is the proteasome inhibitors. And as you can see in red, they started off with Velcade proteasomib, which was the first generation proteasome inhibitors. But we do have other proteasome inhibitors, such as the second generation carfilzomib, which is the Kyprolis, or the ixazomib, which is the third generation. You can also attack the myeloma cell in different other ways, such as the IMiDs or the monoclonal antibodies. And so probably we will choose a combination of 3 or maybe more to kill the myeloma cell, especially in the relapsed refractory setting. But which to choose in the relapsed refractory setting, this is the most important. Next slide, please. Next slide, please. Yes. This is the treatment algorithm. And probably, had they chosen as first line a Velcade-based regimen, then they choose a lenalidomide-based regimen, and the other, and vice versa, especially at first relapse. However, these days we usually choose upfront a regimen of both, together with dexamethasone, which is the VRD. This is very common. And so for salvage therapy, whether a refractory case or whether a late relapse, this is not going to work on its own. I mean, choosing one, if you have not used it before, this is not going to work. You need to choose something else. You need to change either the proteasome inhibitor or the IMiD to something more impressive. So maybe the second generation or the third generation. And also, if it is beyond the initial relapse, maybe 2 or 3 prior lines, or maybe more than 3 prior lines, or post stem cell transplant relapse, then you need to add not only a second or a third generation proteasome inhibitor with an IMiD, but also you need to add a monoclonal antibody. So let us look again. Next slide, please. Next slide. Yes. Look at the proteasome-based regimens that can be used, that have been used with relapsed refractory multiple myeloma, and I need to look at the green squares or the green rectangles, and look at the median progression-free survival in months, and they are very low, 7 months, 9 months, 8 months. So it is not really feasible to use a proteasome-based regimen with relapsed refractory multiple myeloma. Velcade has already been used, so when you use it again, it's not going to be very efficacious. Next slide, please. And so we look at the second generation proteasome inhibitor, which is the carfilzomib-based regimens. And there are many that has been used either in combination with dexamethasone or with Revlimid dexamethasone, or in combination with pomalidomide or daratumumab. And as you can see, the overall response and the median progression-free survival in months is high. It can reach up to 18 months or even 20 months if used with a monoclonal antibody. And this also applies to the overall survival. And so you are helping the patient to gain another remission, and you are helping to progress to increase the progression-free survival and the overall survival and delay the next relapse. Next slide, please. And this goes also to the ixazomib, which is the oral proteasome inhibitor, third generation, which is the tourmaline study, and it also gave good results. Next slide, please. In this symposium, we are going to focus on the ASPIRE. I thank Amgen for allowing me to discuss the ASPIRE, the ENDEAVOR, and the ARROW trials with you. And the ASPIRE study design includes KRD, which is the addition of Kyprolis to Revlimid Dexa versus RD alone. And in this trial, they chose to start with carfilzomib, 27 milligrams per meter squared as of the second cycle. The first cycle was the first 2 days of the first cycle, they start with 20 milligrams per meter squared, and this is to be given over 10 minutes in IV infusion in combination with lenalidomide dexa versus RD. But at that point, they wanted to use the carfilzomib only for 18 cycles. After 18 cycles, they were omitting the carfilzomib. And also the last few cycles, they also omitted one of the 2 days of the carfilzomib every month. And these are the response rates. And as you can see in red and in blue, the overall response rates were very, very high, even in early relapse, not only in late relapses. And the complete remission rates were also significant in these patients when they added Kyprolis to Revlimid dexamethasone. Next slide, please. And this is the primary endpoint, which is the progression-free survival. And as you can see in blue, the addition of Kyprolis to Revlimid dexa gave a very good progression-free survival, 26 months versus 16 months in the RD arm. And this was really significant. Next slide, please. Even the overall survival was better. It extended the overall survival by 7.9 months, so almost 8 months gain with the addition of Kyprolis. Next slide, please. And so the ASPIRE trial, we now know that we can save the patient, prolong his life, and prolong the progression-free survival for months on end. And this was also applicable even if the patient had more than one prior line of therapy. Still, it worked. And even if the patient had been exposed to another proteasome inhibitor upfront. So even with the use of bortezomib before, the addition of Kyprolis to RD still gave good responses. This not only applied to progression-free survival, but also applied to overall survival. Even in cases that had been prior exposed to transplant, the addition of KRD, of Kyprolis to RD gave a median overall survival of 57 months versus 38.6 months with the omission of Kyprolis. Next slide, please. The next study that can be effective was carfilzomib versus bortezomib, because they had noticed that with the use of Kyprolis, even in cases that have had bortezomib before, still it gave good results. And so they wanted to compare carfilzomib dexa versus bortezomib dexa, so second generation proteasome inhibitor versus first generation proteasome inhibitor. And in this study, the carfilzomib was in higher dose. This was the 56 milligram per meter IV dose, and the ASPIRE study was only the 27. Why they increased the dose? Because they were more courageous. They were a little bit afraid of cardiac side effects and did not find many side effects with the 27 milligram per meter squared dose. And so they increased the dose to 56 milligrams per meter squared, aiming at more efficacy. These are relapse refractory cases, and let us look at the results. Next slide, please. Yes, as you can see, KD gave better results versus VD in manner of response, whether in early relapse or in late relapse. Next slide, please. And KD extended the progression-free survival by 8.2 months versus VD. Next slide, please. Next slide. How about patients that had one prior line of therapy? Well, this even gave even more better results, and the KD extended the progression-free survival by 12.1 months. And so if you use Kyprolis in a relapsed refractory setting early enough, it can give you better results than if you use it as third line or as fourth line. Next slide, please. How about patients that have had bortezomib before or lenalidomide before? Look at the figures in red. The median progression-free survival using KD was always better. Next slide, please. How about overall survival? Still, KD extended overall survival by 7.6 months. And so patients will live longer if you use KD versus VD in the relapsed refractory setting. Next slide, please. How about patients that relapsed early or patients that relapsed late? Look at the lines in red versus the blue. The red is the KD and the blue is the VD. And whether the patient relapsed early or late, the median progression-free survival was always higher with the Kyprolis arm versus the Velcade arm. Of course, the late relapses were even better, with 22.2 median progression-free survival. Next slide, please. And so they looked at Kyprolis, carfilzomib, and they thought it was the dose was given on 2 days, 2 consecutive days every week. And they thought, how about giving one dose once weekly as a 30-minute infusion? Maybe this is going to be easier for the patient, easier for the doctor. How about the response? How about the side effects? And so they devised the ARROW study, which is a phase 3 study comparing weekly KD, but in the 70 milligram per meter squared dose versus twice weekly KD, but in the 27 milligram per meter squared dose. Let us look, of course, these are 28 cycles. Let us look at the key inclusion criteria. And these are refractory to most recent lines of therapy, including bortezomib or ixazomib. These are proteasome inhibitors. So these are patients that have been refractory or relapsed after other proteasome inhibitor use. Next slide, please. How about response rates? Yes, the weekly group gave better response rates versus the twice weekly group. And this also showed more CRs and more stringent CRs, not just very good PR response. Next slide, please. How about the response rates by age and renal function subgroups? Because they were afraid that maybe elderly people would not sustain the once weekly dose and they would maybe prefer the twice weekly dose, but this was completely wrong. Whether the patients were less than 65 or more than 65 or more than 75, the response rate was much, much better in cases that received the once weekly versus the twice weekly. How about with renal function subgroups? They were a little bit afraid if the patient had a creatinine clearance less than 40, he was excluded. However, the better the creatinine clearance, the better the sustainability of the once weekly versus the twice weekly doses. Next slide, please. How about response rates by prior lines of therapy? And if the patient had been bortezomib refractory? Well, no matter the prior lines of therapy, no matter the patient had been responsive to bortezomib or not responsive to bortezomib before, the use of Kyprolis gave better responses whatever. And so, even if the patient has had 2 prior lines of therapy or 3 prior lines of therapy, was whether he responded to bortezomib or not before, the once weekly dose gave better results regarding response rates versus the twice weekly dose. Next slide, please. How about progression-free survival? This was the primary endpoint. And miraculously, the once weekly dose gave better progression-free survival versus the twice weekly dose. It was better by 3.6 months. And this reduced the risk of disease progression or death by 31%, which is almost 1/3. Next slide, please. The time progression was prolonged using the once weekly dose versus the twice weekly dose. And so even if you use it once weekly, but in the right dose, you can omit the hazards of going to hospital for twice a week and still get a better time to progression. Next slide, please. How about subgroup analysis with progression-free survival? All subgroups fared better with the once-weekly dose versus the twice-weekly dose, whether the age was young or old, sex, race, baseline line performance status, or baseline creatinine clearance. Even patients with creatinine clearance less than 50 milliliter per minute fared better with the once-weekly dose. Even patients with a performance status that was different, still they fared better with the once-weekly dose. And so patients could sustain the once-weekly dose even with renal problems, even with a different ECOG performance status. The progression-free survival was longer in the weekly group versus the twice-weekly group across all subgroups. Next slide, please. Still, other subgroup analysis, they compared patients that were high risk or standard risk regarding the cytogenetic abnormality, whether clinical stage upfront, the lines of previous treatment, whether they had been previously transplanted or not, whether they were refractory to botulism or not, refractory to lenalidomide or not. All groups fared very well with the once weekly versus the once weekly fared better with all groups, except maybe the standard risk group, it was the same. So progression-free survival was longer with the 1 weekly versus the bi-weekly, whatever the patient had. Next slide, please. How about overall survival? Overall survival at 12 months was 76.6% once weekly group versus 71.9% in the twice weekly group. This was not really significant, but we're not comparing oranges to apples. We're comparing Kyprolis to Kyprolis. So this means that weekly will not diminish the overall survival. In fact, it is almost the same. Next slide, please. How about treatment exposure and dose intensity? Did the people that receive a high once weekly dose, did they tolerate the treatment and receive a high dose intensity of the drug, or did they interrupt the drug? And the answer is that no. The median treatment exposure was longer in the weekly group versus the twice weekly group. That means that they tolerated it better. And the relative dose intensities were comparable between the two groups. Next slide, please. How about safety data? Safety is very important because now you are giving a very high dose of Kyprolis, 70 milligrams per meter squared, on 1 day. And so they compared all grades and grade more than 3 or equal to 3 adverse events regarding anemia, diarrhea, pyrexia, bronchitis, back pain, insomnia, cough, upper respiratory tract infections, nausea, headache, and overall safety profile was comparable between the treatment groups. That means that even if you give it once weekly instead of twice weekly, still the patient is not going to suffer regarding safety issues. Next slide, please. And this is the safety subgroup analysis. And as you can see, whether the patient was less than 65 years of age or above 75, whether the patient had a relatively low creatinine clearance or a good creatinine clearance, still he tolerated the drug well. If you want to look down, very, very down, and the third from below, adverse events leading to carfilzomib discontinuation, comparing the once weekly to the twice weekly, there was not really a big difference. Next slide, please. And so, how about quality of life? Yes, patients receiving weekly Kyprolis reported dosing more convenient and reported greater satisfaction compared with patients receiving twice weekly dose. Patients receiving the once weekly reported improved quality of life using many parameters of quality of life measurement. I have to point out, there was one slide missing. I have to point out regarding hypertension and cardiac failure. Well, they compared the once weekly to the twice weekly, and there was no real difference between the incidence of heart failure, even with the use of the very high dose. In conclusion, the relapse refractory multiple myeloma treatment horizon is broadening. Combinations, including new proteasome inhibitors, IMiDs, and monoclonal antibodies are giving good results. Carfilzomib once weekly in combination is both safe and effective, even in heavily pretreated relapsed refractory multiple myeloma patients. Novel therapies will even make the future brighter. Thank you. I'm open to questions.
Thank you so much, Professor Dr. Mirvat. It was a great presentation in such a rush after this technical issue we had earlier. Thanks for all of our attendees. Thanks for Iris for doing their job in the back office. And hope if there is any question, we can have one, or else we can shift after thanking Amgen for their sponsorship to the next session.